Good afternoon to everyone. It is such a joy for us to join you today. Let me say welcome to Let's Talk with Dr. Carson Greene. I am Pastor Wayne Knowles and I'm filling in for Dr. Carson Greene. He's a handsome guy, but I'm just filling in for him today. And I hope and trust that our session today would be a blessing to you. We do have a very special topic today, and that has to do with breast cancer. This is the month for celebrating breast cancer, and we hope and trust that as we go through this series of information sharing with our very special guest, that it would be a blessing to you as well. Today, I have a special co-host with me, and it is none other than the beautiful Shireen Semper. Shireen is a fifth-year medical student at the University of Morelos in Mexico. That's our Seventh Adventist University there. And so I want to say welcome, Shireen, and greet our guests who are on Second Advent Radio, on our Facebook channel, and also our Facebook page, and on our 2 YouTube channels. And you will also introduce our guests to us as well.
Thank you so much for your kind words, Dr. Knowles. Our first panelist that we would have today, her name is Mrs. Mahalia Roberts Alexander. She's a certified occupational health nurse specialist, and she holds a bachelor's degree in oncology. And she has so kindly accepted to be a part of this program today. So we'd like to welcome her at this time. Our second panelist is Dr. Monica Osborne-Stevens. She's a family medicine physician, and she has a subspecialty in diabetes. And our third panelist that we have today is Dr. Avinelle Henry. Dr. Avinelle Henry is a graduate of the Loma Linda University School of Medicine, and she's currently in her 3rd year of residency in obstetrics and gynecology at the Montefiore Hospital in New York. And we're so delighted to have all of them here with us today to share their knowledge with us and the viewers who are here watching about breast cancer.
All right, thank you so much. So listeners and viewers, you have heard and been able to identify who our guests are. We would like to really wish Dr. Greene speedy recovery before we get into this program. And we hope and trust that this program will be an eye-opener for some, a learning experience for some, a lifesaver for others as well. So stay tuned and please let someone know that Let's Talk with Dr. Carson Greene, filling in today as host by Pastor Wayne Knowles and Shireen Semper, that we are on air, we're live, and we are ready to share some very important information with you. As we begin today, we want to give our first question to Dr. Monica Stevens. As we look around the world, we know that breast cancer is a very prevalent disease around the world. And so it is quite fitting that we have this particular discussion today. Before we deal with the specifics of breast cancer, let us just explain what cancer is and why we should be concerned about it. Dr. Stevens, you may begin with this particular topic.
Good afternoon, everyone. It is a privilege and a pleasure to be on Let's Talk once again. So cancer in general, what is cancer? Cancer is basically the uncontrolled division of abnormal cells. That's simply what it is. So what happens in the body, all healthy cells, they grow by division, and they do whatever they have to do depending on which part of the body they are, and then they die. However, with cancer, the cancer cells, they become injured, whether by internal injury, whether by genetics or an external factor, something in the environment. And so these cells begin to mutate. And once they begin to mutate, they start dividing even more rapidly. And they start behaving a little bit abnormal from the parent cell. And then when that happens, they don't die. Cells are programmed to die, a process called apoptosis. That's programmed cell death. And these cells, they don't die. And so they just keep rapidly multiplying and they form masses. And if they go through the circulatory system, that's where you have the spread that's called metastasis. So in a nutshell, that's just basically how cancer cells act. They get damaged, the DNA damaged, they mutate. Once they mutate, they start dividing rapidly and cause havoc almost anywhere in the body.
You know, that's such an interesting definition that you gave about cancer. So cancer is a group of different diseases characterized by the development of abnormal cells that divide uncontrollably. But is breast cancer just a matter of where cancer is located, or is there something else to it? I'm just throwing out the question to anyone, so anyone feel free to answer.
So the thing with breast cancer is, and I'm not a special breast cancer doctor, but in OBGYN, you know, we take care of women, we kind of advise them in terms of health screening, which I think we'll get into later. But yes and no. Like Dr. Stevens was mentioning, any cell in your whole body kind of has this same lifespan or life plan for the cell. So in some ways, yes, breast cancer is just cancer that happens in those tissues. But because those tissues have their own special functions, their own special things that they're supposed to carry out, when cancer happens in that areas, the way that the symptoms present and the way that it affects your blood cells and your other organs is a little different from other types of cancers. Like the places your doctor will look to see if you're being affected, they're all kind of special to breast cancer. But in some ways, yeah, it is essentially the same principle of cancer, but it's just happening in those tissues.
All right, excellent. That brings me to a question that is somewhat personal, twofold. My mom was diagnosed with breast cancer, but my dad wasn't. So oftentimes we hear of breast cancer, we think of women. What about men? Can men also develop breast cancer? And if so, is it something that happens often enough for us to be concerned about it? I'm gonna ask Mrs. Alexander to come in at this point in time.
Good afternoon, everyone, and thank you again for having me here. That's a very good question, Doc, because as much as it is not common among men, men do develop breast cancer, some called gynecomastia, and it starts in the duct. What is the duct? Well, the function of the breast, there are lobes and duct. The duct usually carries the milk, right? So it's very rare if a man develops breast cancer in the lobes, which is more common with women. But from my practice, when a male do develop breast cancer, it can be because he would have had a history on his mother's side. So there is a genetic link as well. However, it is a lot more devastating psychologically as well as physically, because we don't think that men get breast cancer. But as I was taught, who get breast cancer? Everyone that has breasts. And males do have breasts, even though they have less tissue, but they do have breasts and they can be affected. And the treatment more or less aligns itself to the treatment that the woman would receive. But the psychological part of it is a little more tedious with treatment for the male, because it's something they don't expect and it's very rare. So for instance, I would have seen probably about 2 in my practice over the years, but it is something that happens.
All right, thank you so much. Just a little follow-up before we get another question from Ms. Semper. So men do have to be careful as well. Am I correct in that?
Yes.
Careful but not fearful. What would you say?
Careful, not fearful.
All right. Anybody else would like to comment on that? Because we know that this is not an area often discussed. That's why I wanted to do a little follow-up on that. Anybody else would like to share?
If I could say something here, Dr. Alexander is so right. Once you have a breast tissue, you can develop breast cancer. And males also have breast tissue. And whereas it is more common in females, so we're averaging about 1 in every 8 to 11 women in their lifetime could develop breast cancer. But with males, it's 1 in every 1,000. And right now, they have in 2010, 2021, at the end of this year, it is estimated that about 2,800 males will develop breast cancer and 530 of them will die. On the other hand, 282,000 women will develop cancer at the end of the year, and about 43,000 of them will die. So you can see how very more common it is in females. But if we lose 530 of our men, that's still a lot, right? Though it is rare. And it's about just 1% of males will develop breast cancer.
Okay, thank you
I
so
think
much.
it's such an important point that we're highlighting right now, because as we said, Mrs. Alexander and Dr. Stevens, that men often don't think that they can get breast cancer. So a person's gender is not a determinant factor of whether they can develop breast cancer. But before we deal with the specifics of breast cancer, I think many of us would like to know, our viewers, myself included, is there any specific thing or any specific action that I can do or our viewers can do that can increase our risk of getting breast cancer? Is it something that has to do with lifestyle? Can anyone share any light on that?
So,
Okay, when we
go ahead, Dr. Osborne.
Okay, I think I'm taking the easy questions earlier, so then later I'll leave the hard ones for you guys. Okay, in medicine, whenever we think about a disease, we categorize them in terms of the causes. And we mainly think about genetic causes, environmental causes, and lifestyle causes, all right? And so definitely that is a yes to breast cancer. Our lifestyle practices can contribute to a woman or a man developing breast cancer, because depending on our practices, it would increase or decrease our risk.
Just some more on that in terms of risk. Like, I love how Dr. Stevens put it in those categories, because it's so true of any disease, basically. But a small plug, don't mean to take us back to male breast cancer, but a small plug for knowing your family history. A lot of times we are not accustomed to sharing about things, in our culture. We just say, okay, this person's sick, this person died, maybe they had cancer, but a lot of families are not in the habit of sharing the specifics of people's diagnosis and how old they were and what happened. But that is such an important thing for you to know as a person. If you know there's anyone in your family who has had cancer, ask those questions if you're a man or a woman, because knowing that information, lifestyle factors, they are very important, but a lot of times the genetics are the devastating factors because we have no control over them. But if you have that information, you can kind of have certain conversations with your doctors, be aware, be kind of on the lookout for different things. So it's just a small plug for knowing your family history and, being open within our families of sharing.
And Sister Avinelle, if I could jump in here again, that's a very important point. I'm glad you went back to males, because it is found that with breast cancer in males tend to be a lot more aggressive. And why? It's because males stay longer to go for treatment, because they're less aware that it can happen in males and how common it is. And so they experience a lump in their breast of like, oh, it's nothing, and they ignore it for a longer time because they think that, oh, breast cancer is just specifically to females. So they need to be more aware. So this is what we're doing today, creating awareness both among our men and our women.
All right, thank you so much.
Before you go on, I just want to add, as well as with the family history, the environmental history plays a great part. Because sometimes your work environment predisposes you to being affected to cancer, as well as and as Dr. Henry would have said, the family history is so devastating, because sometimes, as I say to my patients, it's like you can't catch a break. I've seen families from mother, grandmother, aunts, niece, the entire family, same as with males. And forgive me, yes, we are dealing with breast cancer. But I also will always touch on every single cancer once given the opportunity. So prostate have the same affinity, the same makeup, where you look at the grandfather, the father, the uncle, the sons, and you go straight down. And sometimes you are working and you expose the chemicals and all those things on the job, the environment, and you become, how should I say, a patient with cancer. Just to add with the family as well as the environment and the lives.
All right, thank you so much. It lends another question as we speak of lifestyle. It is one thing to say lifestyle practices can lead to it, but what are some of those specifics? Because for our listeners, they would like to know, do this, don't do that. So can you please share with us some practical things that our men, I'm targeting men today because I'm seeing the need for men to have this awareness, but also the women are probably a lot more aware. But what are some of those specifics that men and women can look for in their lifestyles that can help to prevent breast cancer from happening? Anyone could take this.
Okay, so lifestyle, we speak of things that you can change. So hence the word lifestyle. If you make a conscious effort to change it compared to family and somewhat environment, you really don't have much control, but you have control over the lifestyle. So things as smoking. Smoking have shown to be one of the #1 causes of cancer, all types of cancers. And not just smoking, but secondhand smoke and third-hand smoke exposure to that have shown to increase the risk for cancer. You're looking at your diet, and I am always blessed to say we follow the Seventh-day Adventist diet, which I am now teaching to my patients. And what is that? You're eating food which is very healthy, vegetables and all those things. But when you look at the outside world, you see diets that is high in fat, low in fruits and vegetables. Those are things that you can change. Lack of exercise. And while I'm not speaking about going to exercise as an Olympian, we need to be conscious of getting our heart rate up at least 3 times a week, more than 15 minutes. That is the type of exercise. And it can be done as a family to encourage the bonding and all the love and everything that goes with it. On protected exposure to the sun and the UV rays. And of course, I know Dr. Osborne could speak now until tomorrow about obesity, right? Which is causing, so besides cancers, all the cardiovascular and all the diabetes, all those conditions. So lifestyle is a conscious effort, and it's not for today. And you know, it's like when persons get the flu, it's the first time they're going to drink a glass of orange juice. But all the times before you had the flu, how many times did you actually had enough fluid? How much drink? The lemon, the lime. Well, I'm very practical, eh? So I'm not talking about things that you have to go and find in the grocery. I'm talking about things you could get in the backyard. You make lime juice, you boil the moby back, things like that. All those things are in lifestyle. And eventually you will get yourself to a place where you have a good weight, a healthy weight. So this is the word I'm using, healthy, because people tend to think if you're slim or you're skinny, you're healthy. And I know the doctor on the call could attest that there are patients who are very small and it's other medical conditions they're dealing with. So healthy weight, healthy blood pressure, healthy blood sugars, and all those things are attributed to your lifestyle. And I want to touch a little bit on smoking before I allow somebody else to say something. How do we know when someone smokes? Without seeing them putting that cigarette to their lips or their mouth? It's because of the sweat, the clothes, and all those things. And your husband or whoever it may be a smoker, so you're not smoking. But then you come to the clinic with a lump in your breast, you're diagnosed with breast cancer because of the exposure to the second-hand and the third-hand smoke. So if you could stop all those things or really get better at it in time, those lifestyle practices could decrease the risk tenfold.
Okay, wonderful. So there are many things that we can attribute to developing cancer. We said smoking, we said we need to exercise more, or there's some things that we can do to decrease our risk, such as eating well, eating more fruits and vegetables and stuff like that. So it's a multifactorial thing and it has various dimensions. But I am interested in knowing, I think Dr. Stevens would have highlighted this before, that it is more prevalent in women, but how concerned should women be about the possibility of getting breast cancer?
So in general, based on like, I think we mentioned some of the numbers before in terms of world data, but especially in the Caribbean, we should be hyper aware when we, let's say, the ages change for the cutoffs over the years as we have new data and different kind of evidence. But once a woman is postmenopausal, or you're anywhere around or peri or near to menopause, so this is what we think like women in their 40s, their 50s, you should have a switch in your head that means that, okay, I actually need to be on the lookout for this, as in the average woman. Some of the things that make you more at risk for breast cancer are things that we don't even think about. Like for someone who maybe there's some data that shows, and again, it's not like hard and fast, once this has happened to you means you will have cancer, but just some of the things that put you at more risk. Like if you had your first child a little later on in life, you could fall into a group that could be at a little bit more risk. If you have it in your family, like we've been saying, if you've had your period, like for a more extended period of time, like you were really young when you started your period, all of these things that we don't think about regarding ourselves every single day. For women especially, it is actually very, very prevalent. I think it's probably the number one in terms of cancer, oncology related deaths in women in the Caribbean. I think breast cancer is pretty much number one at this point. Beating out a lot of other devastating things. So when you think about yourself and your life, like we mentioned, obviously every single one of these facts that we have said today, you might not remember to the letter of the law, but I would say that any woman who is listening who is peri or close to menopause, or any woman in their 40s, even if you're still having your period every month and you're not having any menopause symptoms, you should begin to think, okay, what is my risk for breast cancer and what am I going to do about it?
All right, thank you so much. We're having a number of questions coming into the chat. So at the bottom of the hour, we'll take some of these questions. But as it is being discussed this afternoon, I'm realizing that breast cancer is a very dangerous disease. And so it shouldn't only be a matter that we discuss it in Breast Cancer Awareness Month. But my question is it a death sentence? I'm going to ask Dr. Stevens, is it a death sentence?
Well, many, many moons ago, we could have said it was a death sentence, but in today's world, in this age that we're living in, it's not a death sentence because we have learned so much about cancer. And breast cancer, I think that's the number one cancer where the most money for funding in research is being poured into. And over the years, we have been seeing a decline in breast cancer, especially after from the 1990s. We noticed that breast cancer has been declining. And that is because women are more aware. The treatment options are better. They're more individualized. They're better drugs that have less side effects. And so once a woman take charge early and start doing her screenings early, there's no reason why a woman cannot live a longer life than before. And I want to talk a little bit about screening because that's where it starts. Early screening means early detection. Early detection saves lives. And so as now the research is saying, as early as in your 20s, the woman is supposed to start SBE, that's self-breast examination. So women are supposed to, young ladies are supposed to get to know their breasts. Women, don't be afraid to touch yourself, standing in the mirror.
All right, seems like we lost Dr. Stevens there for a little bit. But Dr. Henry, can you?
Yeah, as I said, I can pick up with the self-breast exam, and that's actually a great point. In OBGYN, that's something that I tell my patients every year when they come for their annual. We talk about and we go over what we call breast awareness. Like Dr. Stevens was saying, there's no kind of beginning time. In terms of breast self-exam, it's really not a very technical thing. It's just getting to know your baseline. Is essentially how the way you look at your face in the mirror every day. You know, you're getting ready for work. If you all of a sudden see something, you say, oh, what's that? I've never seen that before. But that's because you look in the mirror every day. The thing with breast self-exam is what I tell my patients, it's when you go to bed in the morning, in the night, you're just bathing, you're using soap anyway, just get to know what your skin looks like and what your breasts feel like normally, and just kind of make it a habit. So if you do it every month around the same time, for our women who are having regular periods, a couple of days after your period ends, that's usually a good time to just see, okay, this is what it feels like. Because there's sometimes you will have different types of changes and your breast tissue may feel a little different and you may be concerned, but the next time you see your doctor, you can bring it up and they can describe it, they can reassure you or put you on to the next step. But that all starts with this kind of regular breast self-awareness. So again, the things to think about are kind of regular intervals around the same time every month, a couple of days after your period ends. Hormonally is a good time. And it could be as simple as just when you're bathing, just palpating or touching your breast and understanding what it feels like normally.
So before we take one from Miss Semper, here's the other question. It's not a death sentence, but should we be worried? Someone discovers a lump. Should that person be worried? Mrs. Alexander. Please unmute, yes.
Thank you. I think that person should be concerned. I don't like to use the word worry and I don't like to use the word death sentence because most times when you think it's a death sentence, you already start to limit your options. But this is what is going to happen to me. I'm going to die anyway. I'm just going to leave it alone. And by the time you take to get to us, it would have already spread. And there's a lot more work to be done. But with early detection, as Dr. Henry and Dr. Osborne were saying before, early detection, there's different stages where we can pick you up at 1, probably 2, and you have good options. But I just want to add on to what Dr. Henry was speaking about with the breast examination. A few years ago, it was stated, hey, we don't need to do self-breast examination. We could just go ahead and do the mammogram and the ultrasound. And what the research showed that 99.9% of women will come to a doctor saying, I felt a lump in my breast. They do not have an ultrasound, they didn't have a mammogram. They would have gone to those things. And what I tell my clients, any change is worthy of being concerned. So not worried, but being concerned. So you firstly, you need to know yourself. So you need to look at your breasts. What do they look like on an ordinary day? Before child, after child, no child. So you will be able to identify all the different changes. Now, I also say don't create a checklist, right? Because it could be anything, it could be something. So you're looking at thickening of the area. You're looking at dimpling. You're looking at if there's any discharge, if there's any lump, any bump. And when it reaches the bad stage, what we call pour the orange, where it actually skin changes or the nipple goes inside inverted. Those things are not to sit down at home and say it will disappear or drink some bush medicine or something like that. So I don't want you to say, be worried, but I want you to be concerned. And those are things that, listen, I need to go to my practitioner. You don't need to see a specialist at this time because they now will now refer you to the specialist or the surgeon and all those things. But speak to someone. And I have lost many good friends with this disease because they took too long. They felt ashamed. And women, yes, we are speaking about the male as well as the female. Something about us women, we care for everybody else but ourselves. And we feel as though it's a burden to ask or speak out. But this is where the friendship and the love in the church and the love among workers and among the brethren must be real. So if by the time you say to me, Mahalia, this is what is going on, I'm take the day off and take you to the hospital. I'm going to take you to see someone because there are changes going on and we need to investigate because we are concerned together. We are not worried, but we are concerned. And with, oh, hi, Dr. Osborne, you're back. With the new type of technology and investigation and medication, there's good prognosis. But when you sit down home and you reach us with a stage 4 with metastases in the bone, and the liver and the lung, there's only so much we can do at that time. And of course, there are different types of treatment within oncology. So where could have actually been receiving treatment, we now put in a category called palliative, where we are looking at quality of life more than quantity.
I like the phrase that you've been saying, that we shouldn't be worried, but we should be concerned. I'm actually taking oncology right now in class, and one thing that the doctor constantly highlights is that early detection is the key and that we have to do regular checkups. But how often, or how soon rather, should a person start screening? How soon should a person start these checkups?
Okay, if I can jump back in here, me too. I apologize for that technical difficulties.
Yes, welcome. Good to have you back.
As knowledge increases, things change in medicine. And sometimes people would accuse us of not knowing what we're doing, those of us in medicine. But we have to keep doing research, doing surveys. We have to just keep assessing the situation as we go along, and we call it evidence-based medicine. So whatever we practice, there should be evidence. It should be evidence-based. We should have done some work, some study on it. And so right now, the American Cancer Society, initially they said screening in terms of mammograms should start at the age of 40. But recently they're saying that a woman should have the choice between the age of 40 and 44, whether she wants to do a mammogram or not. But at the age of 45, they are recommending that a woman does her annual mammogram up until age, every year up until age 54, and age 55 and over every 2 years, okay, until the woman has about a little over 10 years of life to live, they say. However, you still have to sit down with your doctor and look at your risk factors, okay? And this is why right now, breast cancer treatment is very, very individualized, because they realize one shoe does not fit all. And so you have to sit down with your doctor, because if my mother, aunt, sister, and an uncle had breast cancer, and I am a 30-year-old woman or even 35, and I present with a lump, my doctor should not say, oh, you're fine, just wait until you're 40, all right? So it's very important that you sit down and have that conversation with your doctor so that they could gather all the family history, all the necessary medical history about you, and make a determination going forward. So those are the main guidelines initially when you're younger. And I jumped in as Dr. Alexander was talking about how they changed. They used to say, oh, forget about the breast self-examination, and that is so true. But now they're recognizing that you as a patient, you come to the doctor most of the time because of what you feel, because of what you see. And so if we encourage women to know more about themselves, be able to look at their breasts, look and touch, then they would present much earlier than if they wait until they feel a lump because they have not been examining themselves for a long period. But why a woman would not do a mammogram before the age of 40 is because below the age of 40, the breasts are considered to be more dense, right? And when you look at it at a mammogram, everything will look white and hazy. So for a woman who's younger with dense breast tissue, an ultrasound can be used, but they now have the breast MRI, which is the gold standard for a young female who have dense breasts. But of course, we don't have that here. But it's a very useful tool that we can use. But once there's an older breast over 40, you have your yearly mammogram. Later in life, you could have it every 2 years.
Okay, so just a follow-up question, because we mentioned about mammograms. I'm not sure about the cost of it or how expensive it would be for a woman to do these tests annually. But earlier, Dr. Henry would have touched on doing self-examinations. How often should they start with those examinations?
So self-examinations, actually, I talk to even my adolescent patients, honestly, because the principle of self-breast examination is getting to know your body and getting to know your baseline. Because if you come to see me every year for your annual visit, or let's say you missed the appointment, it's every 2 years, yes, I have been to school, or yes, etc. Yes, Dr. Stevens would have seen 100 people that day, but you know your body. And if you have been looking and observing and touching your own self, you can tell me very accurately, as like this is what the research has shown, you can tell me very accurately something is wrong. So I encourage all of my patients, literally once they have breasts, if they're teens, if they're in the 20s, I tell them, take a look. Okay, look at what they look like in the mirror. And like I said, these are kind of the habits. And sometimes I think this is probably a different panel discussion, but as women in the church, a lot of the times, we, like Dr. Alexander mentioned it briefly about how we kind of neglect ourselves in favor of other people. But I think an awareness of your body as a woman, as a Christian woman, is also something that we need to talk about, because I think in our wanting to stay away from like sexual immorality and impurity, we kind of demonize our own bodies so much that we are not aware of them. When I tell you to touch your breast and to know what it looks like and what it feels like, I'm not talking about a sexual thing. I'm talking about getting to know yourself. And a lot of women probably listening right now are almost dissociated from their body and what it actually looks and feels like, just in the name of trying to stay away from things that are, obviously harmful. But awareness is really for everyone. So young women, teens listening, if you've never stood in front of the mirror and looked at what your breast looks like, please do that today. And then from next month, when you have your period, let's say like 2-3 days after that, start to do it every time.
All right, thank you so much. You would not believe that we are a little more than halfway through our program, and it is such a joy to hear the amount of information we're getting today. As a matter of fact, if you're listening to us on Second Advent Radio, our topic today is on breast cancer awareness. If you're listening to YouTube, Facebook, we want you to tell someone it's not too late to join this very, very dynamic discussion. We have some amazing guests in the field of medicine. We have Mrs. Mahalia Alexander. We have Dr. Avinelle Henry, Dr. Monica Osborne-Stevens, and my very capable and able co-host, who is also in the medical field, almost at the point of completion of a medical degree, Miss Shireen Semper. And so we have a dynamic team, and we want you to join us. We have so many questions this afternoon on YouTube. I don't know if you have many from Facebook, Mrs. Semper. Miss Semper, do you have any from Facebook as yet?
Yes, I actually do have a question here from Facebook. So one question that one viewer wants to know is if the quality of the breast tissue influences the prevalence of breast cancer. And they gave an example here. They've said that they've heard that persons with bigger breasts are more at risk for breast cancer. Is there any truth to that? Dr. Henry?
Okay, as a blanket statement, I want to say no. There's not like, if you have a small breast, you should equally be as aware of them. The thing is that sometimes if you have larger breasts and you are less aware of them, you can miss some smaller signs that could be earlier. So that if you imagine kind of how research works and how studies go, they measure, okay, how many people have the disease, how many people suffer these consequences, but they're what we call confounding or contributing things that affect that data. So if someone tells you, hey, look, it looks like women with larger breasts have worse cancer, it could be because of the fact that it can make it harder to detect a mass when it's earlier on, and make a mass sort of difficult for even the patient or the provider, if it's not the provider that experience in that kind of way, to detect. But arbitrarily, just because you have larger breasts, that doesn't make you at increased risk for cancer. But if you have larger breasts as a part of an overall increased body profile, like if you have more obesity, now for a different reason, you are at increased risk, but it's not simply the breast size.
Okay. All right. We have been discussing breast cancer being prevalent within your family. Someone is asking here, what about if it's on both sides of the family? Is it more of a danger for that individual? What would you say? Let me ask Mrs. Alexander.
Definitely, as we would have mentioned before, the risks will be higher because now you have both maternal and paternal risk where you have both sides of the family affected with breast cancer. But that does not mean, and I want to emphasize, that you will get breast cancer. Because I have seen persons who had the familial genetic link, and this is where research again, and I so appreciate Dr. Osborne and Dr. Henry when they keep speaking about research, because oncology, cancer is ever evolving. And a lot of work is going into gene therapy, a lot of work is going into immunotherapy and all those things to treat better, because we see an increased risk where persons have that link. Those breast cancer link, the BRCA1 and the BRCA2, and that increases the risk. But because you have knowledge of this is where you have to make a conscious effort to take better care of yourself. So you're gonna make sure you have a healthy weight. You're gonna make sure that you don't have those bad lifestyle practices. You look at your diet, your nutrition, your rest. Stress is another aspect of cancer care, and the cause of cancer, it hasn't been outlined directly as yet, but we are seeing where persons who have high stress jobs are more prone to having cancers. So you're looking at the psychological and your mental health as well when it comes to cancer. So it's not only just the link, but you are now more aware, hey, both mother and father side, I am in the middle of this thing. I need to take better care of myself. I need to be more cautious in what I do, my lifestyle. Don't develop all those bad practices, and try your best. So you're going to screen earlier. So this is the important thing with the risk as well. They're going to start to screen earlier. So whereas we would say to someone, I believe Dr. Henry was speaking about the mammogram at 40, 44 and all those things. Sorry, yes, Dr. Stevens. You will now tell this person in their 20s to get a mammogram. Go and do some gene therapy. See if you have the BRCA genes and all those different things to put you in a better headspace. And we have known women who are in the public. I remember this one person, Angelina Jolie. She's very known to all of us. She has a strong history of breast cancer on both sides of the family. And what did she do? A double mastectomy. So she took in front before in front took her. But I'm not saying to persons to go that drastic, but just be mindful. I have an increased risk. I need to be more cautious in how I take care of myself. I need to screen earlier. I need to do monthly self-breast examination. I need to do yearly mammograms and all those different things.
Just one other brief lifestyle thing that I forgot to say earlier. There's not, I mean, it's not causative or not exact data, but there's some that shows with vitamin D and calcium. Those are actually very important in kind of the prevention and stuff of breast cancer. So just a simple thing like an early morning walk, it's good for you. It's just that vitamin, D, and you drink your calcium, etc. It's good.
And because Doc went back to lifestyle, Dr. Alexander outlined them so perfectly, but one thing I need to add there is alcohol. Studies have shown that the increase in alcohol also puts you at a greater risk for developing breast cancer.
Okay.
And I also say,
go ahead, Dr. Stevens.
anybody who have sat down with me on a one-on-one or heard me do any talk, I would always say, genetics load the gun, but the lifestyle pulls the trigger. Genetics load the gun, but your lifestyle pulls the trigger. So not because you have a family history, a hereditary tendency to develop a certain disease means that you will get it. It means that your risk is increased, but lifestyle practices also add to increase your risk of you getting that particular disease.
I really like that we're highlighting here facts and evidence-based things of what can contribute or increase the risk of people developing cancer? Because oftentimes we hear lots of stories, and I know it can be sometimes difficult to differentiate between what's a myth and what's reality. For example, I have heard persons say that breastfeeding increases the chance of a person getting breast cancer. Is there any truth to this? I see Dr. Henry, I see our expression there. Can you just share some light on that?
So I just no, I just want to say no in terms of to that myth overall. And actually there is some data, again, it's not extremely robust, but there's some data that shows that breastfeeding is actually protective against breast cancer. So the opposite is true of that. I think it's up to about a year. What usually as an OBGYN, when I'm speaking to my patients about breastfeeding, that's one of the things I tell them, exclusive breastfeeding is great for the baby, et cetera, et cetera. You try to do 6 months, but a lot of the data for cancer specific outcomes show increased kind of preventive or protective measures for women who breastfed about a year. So, yeah.
Yes, that is absolutely true, Dr. Henry, because there was a study done in Turkey and another one somewhere else that showed that women who, this was over 103,000 women this study had, and it showed that women who breastfed for up to 12 months, their risk was 4.3% less than the person who did not breastfeed. So it's actually the opposite. It's not that it contributes to breast cancer, but it is sort of preventative to breast cancer. And there are a couple studies that definitely indicated that.
All right, we do have an interesting question online, and this one seems to be coming out of a position of fear. Maybe someone is afraid of the mammogram, and so they're asking if there's anything that can be done besides the mammogram machine being used. This is an important question. Someone is probably fearful. Who would answer this question for us?
Well, I hope this person is in Antigua, because I can speak about Antigua, because I myself personally have heard prior to me turning 40 some eons ago, that I've heard that the machine, it's really crushes your breasts, especially if you have small breasts. It's really painful and really uncomfortable. And when I turned 40 and when I had mine done, it was not painful. I mean, I wouldn't say I would go for it for breakfast, lunch, and dinner, but it was not painful. It just showed that I was having a procedure. And when I asked the radiologist about it, she did admit that it's a new machine that they had. And it's a good thing I had came in at that time, because I think it was months prior they had gotten that machine. So I think if you go to the Sylvester Bird Medical Center and have your mammogram done, it should be much easier. It should be comfortable for you.
Okay, I do have another question here. Sorry. Okay, I have a question here from Facebook, and someone wants to know, what about the use of contraceptives? Do they increase the risk of a person getting breast cancer? Mrs. Alexander?
Dr. Stevens, you could go right ahead, hon.
Okay, yes. Oral contraceptive pills do increase the risk of cancer. It is a breast cancer specifically. It is a small risk, but is a risk nonetheless because of the estrogen. And I'm sure many of you have heard about estrogen receptor type cancers. And whenever you have extra estrogen in the body, research has shown that they feed cancer cells. Okay, so definitely oral contraceptive pills contribute. So that is another risk factor. And this is why I think it was Dr. Henry that mentioned about women who, if they have their menarche in earlier years and they have the menopause in later years, they would have been exposed to a greater period in their life where they have estrogen in the body, and that too increases the risk. So if you're putting exogenous estrogen in the body, then that will definitely increase your risk as well.
Just a small aside on contraception. There are a lot of different types, because when people think, okay, this contraception or birth control, I find, especially in the church, it's not something that we're very familiar with a lot of the times. And the risk, so if you have taken a birth control pill ever in your life, it does not mean it will give you cancer. The risk is it exists in theory, and it is a risk that you should talk to your doctor before and look at your overall kind of lifestyle and your risk factors when you're choosing a form of contraception. So it's not that, okay, because I need a form of birth control, like you're trying to plan your family, I can't use pills because pills will give me cancer. We don't want anybody to go away from here thinking that. It's just worth a conversation with what are my options. Let's say if you are someone who has a very high like family history we're talking about, or a lot of other risk factors going for you, there could be other options that you could speak to your doctor about. And there's different types of birth control pills, like oral contraceptive pills, that have different amounts of estrogen in them. So all of these things, it's a huge world of possibilities in terms of contraception. And so don't feel like you can't have contraception or you can't have birth control. There's ones that don't even involve estrogen at all. Sorry, I'm getting into OB. I feel very strongly about this. So just to know, there's a lot of options for you that would not put you at risk.
All right, so we've looked at several contributing factors. We touched on stress. We just touched on contraceptives as a potential cause or contributing factor. And we touched on smoking before. But someone is asking not about first, second hand, but third hand smoking. Do you have any data on third hand smoking and whether this can be a contributing factor as well? I'm seeing Mrs. Alexander nodding. Can you please respond?
Okay, so what is the third hand smoke? The third hand smoke is the smoke that the smoker leaves on the clothes, on coming through the pores. And for instance, let me draw an example. One of my real life example, one of my clients, she was diagnosed with breast cancer. She never smoked a day in her life. However, her husband, he was a smoker, but he never smoked at home. So she's wondering now, well, where did I get this exposure from? But what he would have done, when he gets home in the afternoon, he will carry the children for a walk. And the children would stay on his skin. They would take out his clothes, whatever, they'll have fun. And this is where she probably may have had that exposure. That is the third hand smoke we are speaking about, which is still very a very high contributing factor to cancer, because whatever this, so let me go down to what the cigarette consists of, all those chemicals. Remember, we spoke about the environmental factors. So it have the nicotine and all those chemicals, and they combust and they give out this smoke, and you inhale it. What your body does, and I believe it's Dr. Stephen said, cancer is very individualized in treatment because it is very individualized in how it mutates in one body. So someone will have no, nothing will happen to them. But this person now, when they inhale this thing, it goes to the lung cell, and the lung cell from the beginning of the lecture, what is cancer? You just need one cell to react, just one cell to start to split and divide and mutate, and it becomes cancer. So whatever that smoke exposure would have given to you, it ignites a process. And therein, we say the smoke, the third hand smoke, is equally detrimental and positive as just smoking secondhand. And there's research that can attribute to that.
All right, so we're coming close to the end. We have just about 5 minutes. And I believe in solutions, solutions, solutions. We looked at lifestyle, we looked at research, but as we come close to the end, I'd like each of you to make some recommended solutions. A person discovered, you touched on some of these before, person discovers that they have breast cancer. You mentioned before that it's not a death sentence. It should be a concern. But what are some of the most common solutions to assist individuals who have breast cancer? I'm talking about the counseling, the whole gamut, the package, not just the medical, but What are the medical solutions, social solutions that you recommend at this particular point? Anybody, everybody would need to give a little 2
Okay.
cents on
Yeah,
this.
I will go first.
Yes.
I'm going to start, if you don't mind. Prior to the 1990s, almost every female who had a mass in her breast had a mastectomy. It was very common. You have a mass, take off the breast. So much so they take even muscles from the chest wall because they thought we got to get rid of all this cancer. As time evolved and more research had been done, practices has changed. And so a woman steps into your office, say, "Doc, I noticed that I have a lump in my breast." And she starts describing that lump, and I proceed with my examination. And I said, "Yes, I concur, you do have a lump in your breast. What is the first step? What am I going to do next?" We're going to start with some imaging. Depending on her age, we're going to do either ultrasound or mammogram. Okay, let's say she's over 40. I'm going to send her for a mammogram, and then I am going to refer her to the surgeon. Then the surgeon is going to have a conversation with her now based on the size of the lump, where it is located, her family history, her personal history, and all the risk factors that she has. They're going to have that discussion, and then they're going to decide, based on the extent of the mass, are we going to do a lumpectomy, meaning that we're going to just take out the lump and the margin area around the lump, or are we going to do what you call a fine needle aspiration, just aspirate some tissue from that lump, send it, have a biopsy done, and thereafter come back and have the discussion with the patient. Then the other treatments you can do, depend on the type of cancer. Is it hormonal? Is it HER2? Is it triple cancer? Depend on what type of cancer, the stage of the cancer, and even your other chronic illnesses that you yourself may be going through and other medications that you may be on. The doctor is going to decide with yourself what the next step is. And that is why now we're saying a lot more women are surviving, because cancer treatment is more individualized. It's not because I come in with a lump, you're going to take off my breast and say, that's it, because you have the psychological aspect to think about as well. So each individual needs to sit down with, first of all, the family medicine practitioner or GP and have that discussion. And then they can take them through the whole gamut of procedures and tests, and even past the preempt to say even counseling. All of that is going to be a part. It's a whole multidisciplinary team that come into play here. Here we don't have a medical oncologist. We do have medical oncologists, but a radiology oncologists and so many other different persons that can come into play who are vital for the team. We may not have them here. However, we are in a good place. We have lots of patients here with breast cancer. I'm speaking of Antigua, who are survivors, and they do very well now. We have access to a lot of the new drugs that we didn't have access to before. So we are doing pretty well here in terms of cancer.
All right.
Pass it on to the other person. Sorry.
Yes, we only have just about 2 more minutes. So Mrs. Alexander, this is your time.
Okay. Thank you very much. And my takeaway message for you all, short and sweet: know yourself, support each other. Please lend that support. It's not a secret, it's not a death sentence. Cancer shouldn't silence you, because by the time you're taken to become silent, we can be treating you and getting you ready to live a very long, successful, progressive spiritual life. Right? You know your signs and symptoms. Do not look for a checklist to say, well, okay, they say if the breast will turn this color, it have to have leaks, it have to have bumps. No. Anything that is different, that is not unique to you, go seek treatment, ask a question, and please go see Dr. Henry and Dr. Stevens. And if you're in Trinidad, feel free to call me and we'll have the conversation then.
All right. Thank you so much, Dr. Henry. Your final words on this.
Yeah, so my final words, just want to thank you all for inviting me here. It was a lot of fun. I had a good time here today. And just a final word for maybe the women listening who could be survivors of breast cancer, even now, just to remember to support each other, to support people who have gone through breast cancer, because all the things we have been talking about, it is a fight. It takes a big toll on your body. People who have survived just horrible things, they are so strong and so just powerful people to interact with. So if there are any of our listeners who can actually relate to a lot of the things we talked to, I guess my final word would just be to empower them to tell other people, what they have been through, and to kind of use that knowledge and that strength that they have from this experience as a part of their testimony. Cancer, even though if we observe all the lifestyle things we said, unfortunately, we live in a fallen world. And until Jesus comes again, cancer, it seems that it will be around. But God really can bring us through this just like any other thing in our lives.
All right, so Miss Shireen Semper, there's some final words you would like to say as well?
Yes, I think our panelists did an excellent job covering the topic of breast cancer today. And I think that just awareness of breast cancer, of its risk and symptoms, should be something that's public knowledge. Just as we know how to look for someone that has a cold or even now coronavirus, we all know the symptoms and we should be aware of it. And sometimes I feel as Christians, we may feel that if we have a diagnosis of cancer, that maybe feel like God has punched us in the face, so we don't know what to do. However, our secret weapon right here is that we have God's love. And as the Apostle John reminded us, is that there's no fear in love, but perfect love drives out fear. And he knew that in whatever circumstance that he was in, that God would have always been with him and that God loved him, irregardless of whatever situation he was in. So as we're reminded today by our panelists, the more we know about it, the better our chances are of detecting it in the early stages when treatment has its highest potential for success.
Oh, thank you so much. My co-host, Miss Shireen Semper, very well done. And our special guest, Mrs. Mahalia Alexander, Dr. Avinelle Henry, and Dr. Monica Osborne Stevens. As usual, you guys are tremendous people. You're doing an awesome job by helping to enhance the lives of humanity. And the reality is, God can best use those who are healthy. And so let's pray for those who are sick. Let's pray for those who take care of the sick, so that together we can help to advance the cause of God. So thank you so much, and may God continue to bless you. Remember that Let's Talk with Dr. Greene will be on air next week again. Same time, same place, same media platforms. But next week, we have a very special program in the midst of COVID, in the midst of the vaccine debates. There are many persons who are talking about mark of the beast, 666, what it is. The church is somewhat divided at times. But next week we have Dr. Eckerhard, one of our professors from the Biblical Research Institute of Seventh Adventists, to answer questions and to share quite a lot of information on what the mark of the beast really is. So please tell a friend that next week is another week that you just can't afford to miss. Let's Talk with Dr. Carson. May God bless you all, and do have a wonderful day as we continue to do the best that we can to enhance the kingdom of God. Thank you so much, and may God richly bless.